All right, good morning, everybody. Real treat this morning to introduce one of our professors of neurological surgery, Deepak Sharma. And that's not short for anything, it's Deepak Sharma. And Deepak is a professor of neuroanesthesiology and perioperative neurosciences. And why he's so important to us for all the young ones is that he was the founding chief of neuroanesthesia at University of Washington, and he was the founding fellowship director. There was no fellowship, there was no chief of neuroanesthesia. It was just whatever anesthesiologist you got. And he elevated the care of our patients, the science of our patients, the education, true triple threat, considerably in the 10 years that he ran it. He is now the current president of the Washington State Society of Anesthesia. He's the vice chair of the American Society of Anesthesiology. He's the inventor of the transcranial Doppler stimulator. He has multiple funding sources, including the AHRQ, the funding agency for healthcare research. He's got 120 publications, two books to his name, about 180 invited lectures nationally and internationally, and a visiting professor. But the most important thing I haven't said is the obvious. He's an amazing colleague. He's the human you want in your room on the other side of the screen when you're doing a challenging operation. He's calm. He's cool. He's thoughtful. He's really superbly good at what he does. And he's a member of our department. So, Deepak, thanks for sharing your reflections of neuroanesthesia with us. Um, you, I'm going to launch you.
Thank you very much, Rich. Thanks for those very kind words. And good morning, everyone. Thanks for having me. This is a great opportunity. And I'm going to start sharing my slides. Just a quick check. Can you see my slides, Rich? All good?
They look marvelous, Deepak.
Okay, perfect. Thank you. So I'll just dive right into it. Here are my disclosures. None of this should impact the content of the presentation today. What I plan to do today is basically share the story of conception and evolution of the Division of Neuroanesthesiology and Perioperative Neurosciences here at UW. I wanted to take this opportunity to reflect on some of the collaborative advances that we have made together over the years in the clinical space, in the educational spaces, as well as in the research areas. There's obviously a whole lot we have done in the last decade, and an hour or 40 minutes is not enough to cover all of that. So what you'll see here is a flavor of a few items that I thought would be worth discussing. And then I'll briefly touch upon what the future might look like for us in this division and here at UW. So as I started thinking about this presentation, I wanted to first go ahead and look at the history of neurosurgery here, and this is from our website. I'm sure you're all familiar with this. So the Department of Neurosurgery, Neurological Surgery at UW, has been described in three developmental epochs of three different models, starting from 1948 all the way through 2016 is what this figure shows, but ongoing is the destination, translation, and innovation phase. Um, but to understand where neuroanesthesiology came in, I'll give you a very brief history of the Department of Anesthesiology, which actually started as a division within the Department of Surgery in 1954. Dr. Lucien Morris was the first chief of this division, and he interestingly was the inventor of what you see here, the copper kettle, which was the first accurate way of giving inhaled anesthetics back in those days. Anesthesiology became a department in 1960 under the chairmanship of Dr. John Bonica, who interestingly was a very well-known wrestler besides being an outstanding physician and a pioneer in the area of pain medicine. He's widely recognized as a leader in anesthesiology and pain medicine, and our department is really proud to have his name associated with the department. Dr. Bonica was followed in 1978 by Dr. Tom Hornbein as the chair of the department, who was in that role till 1994, and unfortunately he passed away a couple of years ago. I had the great pleasure of seeing him in person uh, in Denver, Colorado, a few years ago, and this picture is from then. But Dr. Hornbein is very well known in the world of mountaineering because he was the first person in the world to climb the west ridge of Mount Everest. What you see here in this picture is this blue line, which basically shows the north face of Mount Everest, and this path is named after him. Dr. Hornbein was obviously very passionate about high altitude pulmonary physiology, and he did a lot of pioneering work in that area. He was then followed by Dr. Fred Cheney, who I'm sure some of you had the opportunity to work with, and he remained the chair till 2007. Dr. Cheney was very passionate about patient safety, and he started the closed claims project for anesthesiology at the national level, which really elevated our department, our profile to the next level. He was then followed by Dr. Deb Schwinn, who was the chair from 2007 to 2012, and then Dr. Mike Crowder, who's still in the department and served our chair till 2019, and then Dr. Burkhard Mackinson, who's the current chair. So it was during the time that Dr. Deb Schwinn was moving out of UW is that we started talking about the division of neuroanesthesiology here at UW. So again, looking back at this timeline, I prolonged this arrow here up to 2025 to make things a little comparative. So as you can see, the Department of Anesthesiology came into being here, and the Division of Neuroanesthesiology came much later. So it's been a relatively short period of time in the long and prominent history of both the Department of Anesthesiology and the Department of Neurological Surgery. Now, why have a division? It's a question that we end up talking about every now and then. Do we need specialist anesthesiologists for every surgical subspecialty? Back when we started this work, there wasn't so much data, but now there are studies that demonstrate at least the value of the surgeon anesthesiology dyads and their association with postoperative patient outcomes. This is a study from JAMA Surgery from 2023, which basically shows the relationship between the number of procedures a surgeon and anesthesiologist dyad does together and the probability of major morbidity after the surgery. And as you can see, there's a linear correlation there. Now, this study was done in Canada, and it looked at patients getting mostly gastrointestinal cancer surgeries. But subsequently, the same group performed another study, which was published in JAMA earlier this year, and they looked at the same effect, the effect of surgeon anesthesiology dyad, their familiarity with each other, and looked at a range of surgical procedures and its association with high with major morbidity. And what they found, interestingly, in this model was that there was an association of decreased odds of morbidity in patients undergoing high risk or low risk GI procedures, gynecological oncologic procedures, as well as those undergoing spine surgeries. So having a team that knows each other worked really well, at least in these scenarios. Now, what about brain surgery? So this is a study from PLOS One. This is from Netherlands, and it compared um, neuroanesthesiologists, qualified neuroanesthesiologists to general anesthesiologists, and looked at certain outcomes in patients undergoing glioblastoma surgery, and found that when a qualified neuroanesthesiologist is involved, then there are some measures that are better and preferable, and these include a reduced length of stay here, um, the total cost of admission, and they also found a reduced use of the anesthetic agents as well as fluids. But more importantly, what you see here in this figure from the same study is that the major complications after surgery, both early as well as late, were significantly lower when neuroanesthesiologists participated in care of patients undergoing glioblastoma surgery. So again, some value to having teams that are experts in taking care of these patients. More recently, this study published in the Journal of Neurosurgical Anesthesiology looked at the relationship between fellowship training and again, the surgeon anesthesiology diet in case of spine surgeries. And this study is also from Canada. And as you can see, there's again a linear association in the probability of in-hospital morbidity in this case, based on both fellowship training as well as the diet structure. So there's enough out there demonstrating the need. And again, this wasn't the situation back when we started this division. But nevertheless, we had a momentum here in the department. The UW Neurosciences Institute was taking off in a nice way. And it was obvious that anesthesiology had to contribute more actively to that aspect. And that's when I was asked to take on the responsibility to lead and start this division. And as I took on the responsibility, the first question I asked myself is, what would this look like, and why would I do this job? And as I started to foresee the future, as I did at that time, I saw that my specialty, neurosurgical anesthesiology, was in a phase of evolution. And there's a little bit of semantics here. So if you think of neurosurgical anesthesiology, it typically conveys that you have an anesthesiologist who's providing care for neurosurgical procedures. Neuroanesthesiology conveys an anesthesiologist who is qualified and has knowledge of a related neuroscience and brings that into the operating room, meaning they have expertise not just in anesthesiology, but also in neuroimaging, in neuromonitoring, in neurophysiology, in relevant aspects of neurocritical care and such. And they bring all those expertise into the operating room. And this is a better model and more effective model to provide patient care. But I wanted this to go farther and look at neurological outcomes beyond just neurological surgeries, and hence the idea of perioperative neurosciences came in. And we became the first division in the country to be called Neuroanesthesiology and Perioperative Neurosciences. As we thought of our services and our strategy, I came up with this plan in brief. So at the core, of course, is neurosurgical anesthesia, meaning taking care of patients undergoing neurological procedures in the operating rooms. But even back then, we knew that interventional neuroradiology was going to expand, and there was going to be a boom there, and it was going to be a big aspect of what we would care for. So this had to be in the purview of this division. It was important to me to have a bridge with the neuro ICU, and we thought it would be critical to have members in the division who would be boarded in neurocritical care and would provide that bridge between the ICU and the operating room. But beyond this, we also wanted to embrace the care of neurologically ill patients undergoing non-neurological procedures. So if you have a patient who has either a tumor or a vascular malformation or epilepsy or what have you, and they're undergoing either an obstetric procedure or a cardiac surgical procedure, we wanted to be a part of that and provide our expertise to that population. And last but not the least, we were very keen on embracing the neurological outcomes of anesthesia. And this was in the context of an aging population where we know that postoperative cognitive outcomes are a significant concern after exposure to anesthesia, irrespective of the type of surgery. And we thought as this field expanded, ranging from delirium to cognitive decline, that the expertise of neuroanesthesiologists would be very valuable in this field. So we wanted to embrace all of this. But I thought of this in a model that would include not just clinical excellence, but also a component of research and education with a crosstalk between all these components. So leading research would inform our clinical practice. So we provide the most evidence-based, updated care to our patients. But at the same time, our clinical experience would generate the important research questions. We thought that our clinical excellence would be translated into advancing our practice through training and education. And at the same time, we would incorporate this in our clinical domain also. We want to make sure that our faculty and our team members engage in research and they learn about it. But at the same time, we also wanted to give importance to research in education. So the thought of this model and encompassing all of this were the broader aspects of what was our vision at that time. And this was all going to be informed by a sense of innovation, collaboration, and teamwork, a public health mindset, which is very critical, I think, for anesthesiologists. And all this would happen in an environment of diversity, equity, inclusion, and justice. So this is where we started, and we decided to call it a division of neuroanesthesiology and perioperative neurosciences. And I became a joint member of the Department of Neurological Surgery. And ever since, every single faculty member recruited to the Department of Anesthesiology in the Division of Neuroanesthesiology has been an adjunct member of the Department of Neurological Surgery, demonstrating our close work. But I don't mean to say that this work was happening in a vacuum. We did have a very rich history of expertise in neuroanesthesia here at UW even before my time. My mentor, Professor Arthur Lamb, who was the chief of anesthesiology at Harborview, and Dr. Alan Artru, who was the chief of anesthesiology at UW Medical Center and still works occasionally after his retirement. They were both around at that time, and so was Dr. Karen Domino, who only recently retired from OR anesthesia. And these individuals had done some pioneering work in neuroanesthesiology, and it was amazing to have that as a fertile ground where we could take the word forward. So we came up with the vision and mission statements. Our goal was to be recognized as a leading division in clinical care education and research in the domain of perioperative neurosciences. And our mission is to advance the perioperative care of patients with neurological diseases and patients at risk of perioperative neurological damage by promoting the integration of excellence in clinical care, education, and research. In terms of how we move forward, my foremost priority was building the right team, which would comprise of individuals with the right expertise in various neurological conditions that we deal with here. At the same time, I wanted to make sure we have a team of expert clinicians, educators, as well as researchers. And we were fortunate to be able to build that over a period of time. And importantly, we started emphasizing collaboration to make sure our division was effectively doing what it was supposed to do to accomplish the goals. Of course, our most important collaboration was with neurosurgery, but we also worked very closely with neurology, neuroradiology, and other departments, and notably also other divisions within the Department of Anesthesiology to make sure we have ongoing crosstalk in all these domains. Now, with all of that, I'd like to just chat briefly about some of our initial successes and initial stories, and I hope there'll be something to reflect here for those who were there at that time. And for those who have joined the department after that, they can have a sense of how our teams collectively worked over the years to accomplish national prominence and to provide excellent care to our patients. So you'll remember around 2015 was a time when endovascular treatment for thrombectomy became really popular. Prior to this, there were some studies that demonstrated that stroke thrombectomy was not an effective treatment, but these three studies listed here and others published in 2015 firmly demonstrated the effectiveness of endovascular treatment for stroke, and we became really busy with stroke care. Unfortunately, however, what became a controversy early on in the management of stroke thrombectomy was the choice of anesthetic technique. Now, obviously, these procedures can be done with conscious sedation or with general anesthesia, and both have their advantages and disadvantages. What happened around that time was that a number of studies were published. These were all retrospective studies. They were all done by non-anesthesiologists with no input from anesthesia. And they had no description of the anesthetic, no incorporation of physiological or pharmacological data. And interestingly enough, they all demonstrated an association of the exposure of general anesthesia to worse neurological outcomes after stroke thrombectomy. Now, of course, it's association, not causation. Um, but as you can imagine, it might simply mean that a patient who has a worse stroke actually needs anesthesia, and it might be the need for general anesthesia that would be leading to the worse outcomes. But irrespective, with the publication of all these studies, the notion of general anesthesia being undesirable for patients with stroke thrombectomy became very broadly embraced very quickly. And as a result, at most places, interventionalists wanted anesthesiologists to not even participate in stroke care. However, given the collaboration we had here, that never happened at Harborview, our stroke center. Interestingly, when these studies were published, I remember writing this letter to one of the journals, pointing out that general anesthesia is not a drug one can order from the pharmacy. It's a very carefully selected physiological pharmacological condition that an expert physician provides to the patients depending on their comorbidities and the procedural needs. But irrespective, around the same time, the Society for Neurosciences and Anesthesiology and Critical Care decided to commission a task force to come out with a consensus statement on this topic. And I had the pleasure of serving on this consensus statement, which basically highlighted the fact that there was no evidence to start not to prevent patients from getting general anesthesia when they needed it. And we recommended that there needed to be randomized controlled trials to address this topic. So what happened next was very interesting. So these three randomized controlled trials, and I'm sorry, I'm not going to go into the details of these trials because my goal here is to share the story more than anything else. But essentially, when these trials were conducted with actual randomization of patients to general anesthesia versus conscious sedation and maintaining the hemodynamics in the same range, so avoiding hypotension in patients with general anesthesia, to everyone's surprise, none of these studies found a difference in neurological outcomes. In fact, when these three groups pooled their data, they found that actually general anesthesia was actually associated with better outcomes. And that was quite a surprise to everyone. But nevertheless, it led the American Heart Association, American Stroke Association to change their guideline recommendation, which initially said it was reasonable to favor conscious sedation, to in 2018 saying that it's reasonable to select an anesthetic technique based on the individual patient needs. So that was very interesting. Fast forward, now there have been at least 9 randomized controlled trials published looking at anterior circulation strokes and stroke thrombectomy. And interestingly, all of these have now found that general anesthesia is non-inferior to conscious sedation. And the pooled data would demonstrate that general anesthesia might actually be favorable for patients undergoing stroke thrombectomy. So the pendulum completely swung in the opposite direction. But when we work in collaboration, this is what happens. So you see time trends for the use of general anesthesia and monitored anesthesia care for our patients here at Harborview. The red color here shows general anesthesia. The green shows MAC, which is monitored anesthesia care. And as you can see, going from left to right, our utilization of general anesthesia has increased over a period of time, allowing us to consistently stick with the best evidence for our patients. Interestingly, however, the anesthesiologist involvement in stroke thrombectomy across the country is very variable. There are at least 5 different models. There are some places where there is no anesthesiology involvement, and we respond only if there is a problem, if there is a crisis. There are other places that involve anesthesiologists as needed. And then I think the least, I would say, the least that should be acceptable is the model where anesthesiologists participate in all thrombectomies. But then there are places where we participate in all stroke codes. And there are very few like Harborview where we have a complete involvement. And what I mean by that is we not only attend to all stroke codes, but we are also involved in institutional stroke QI committees We participate in QI initiatives and engage in education and research. And that allows us to be reflective. As you know, there are comprehensive stroke center requirements for various time measures. Currently, there are no measures for what anesthesia should be doing, but we have been looking at our own efficiency in providing stroke care. And as you can see here, the average time for anesthesia ready for patients with stroke thrombectomy is about 9 minutes, the median time of 8 minutes, and we meet our goal of doing this in less than 15 minutes in about 90% occasions. Not only that, we also look at the hemodynamic goal adherence to patients in this case. And based on the current guidelines, it's recommended to keep the systolic blood pressure more than 140 millimeters of mercury. And we recognize that it may not be possible to always prevent hypotension, but it should be treated promptly. And we capture that information, and then we provide information and feedback to our clinicians to continuously improve the quality of care at Harborview. This obviously has not gone unrecognized. This is something that gets recognized by our comprehensive stroke center reviewers every single time since we got involved. And you can see here a communication from a few years ago where they said the neuroanesthesia involvement in stroke code, including the COVID process, is strong, and this is something that other places should learn from. So our collaborative efforts get recognized at an institutional level, but not only that, it's also recognized outside the institution. This is an editorial from the Society for Neurointervention Surgery in their journal, where our work has led them to start advocating for immediate access to anesthesia for all interventional stroke cases to be a new requirement for comprehensive stroke center certification, which currently it's not. And thankfully for us, they recognize our institution for being a role model in this case. So I think we're able to impact stroke care not just at our institution, but beyond, simply because we have this collaborative model. And obviously, it's important that we engage in quality improvement, because unless we measure what we are trying to accomplish, we cannot improve the basic principles of quality improvement. So the Division of Neuroanesthesiology and Perioperative Neurosciences took on an initiative to be reflective in this exercise and look at quality improvement in domains beyond stroke care. And I came up with this fancy name because I'm a neuroanesthesiologist. So we came up with PONS quality measures, or Neuroanesthesia Perioperative Neurosciences quality measures. We know that there are a number of measures that we record for extramural reporting, for reimbursement purposes, etc. But we wanted to embrace a model where we would look at aspects of care that are relevant to the clinicians and make sense. And we use the Institute of Medicine CEPT model to come up with these quality measures. And I'm going to share some of those with you. So just like stroke, we look at our performance in emergent craniotomies, and we look at anesthesia readiness for TBI. We also look at the hemodynamic goal adherence for TBI based on the Brain Trauma Foundation guidelines, and we provide feedback to clinicians based on this data. We also look at our elective craniotomies. We want to make sure our patients do not get reintubated within 6 hours after the procedure, because that might indicate that the decision to extubate in the operating room wasn't the best one necessarily. And as you can see, very few of our patients require reintubation within 6 hours of surgery. And that's not because we are not extubating most patients. We are actually extubating most of our patients who meet extubation criteria at the end of the surgery. We started looking at pain scores after elective craniotomy. As we all know, pain after craniotomy has been a very overlooked and ignored topic, I would say. And we started the exercise of looking at pain scores within the first 6 hours of surgery. And these are the patient-reported scores in situations where the patients can report their pain scores. And it allowed us to look at the distribution of pain also by the site for both UWMC and Harborview. And it allows us to look at multimodal pain management approaches for our patients to make sure we're looking at not just their neurological outcomes and adequate breathing and respiration, but also taking care of their pain effectively. Notably, we have not had any incidents of a patient requiring naloxone because of opioid overdose. The other aspect that was important was the need to monitor ICP during transport from ICU to the operating room and in the operating room for patients who had an EVD in place. Because those of you who have been here for a while will recollect we had a number of adverse events related to inappropriate management of EVDs, both over drainage and under drainage, leading to complications. And so we implemented a whole pathway, and Abhijit Lele took the lead in this. And we made this a quality measure to make sure folks are actually monitoring the patients during transport and in the operating room, simply to make sure that that everything is working and there isn't a situation of inadvertent under or over drainage of CSF. So, switching gears a little bit, I want to talk about another unique strength of our institution, of our team here, which is transcranial Doppler ultrasonography. This is actually the reason that I first came to UW, and I'm grateful to Rich and Shaker for allowing me to serve as the education director for the lab and be very involved with the lab. As you all know, TCD is a very useful technology, and it has a very rich history here because TCD was actually started here at Harborview in 1980s. We were among the first institutions to have it, and these pictures are of my daughter who's wearing the TCD headband, simply to convey that it's pretty easy to place these headgear on. The one situation where we find it really useful is for the patients undergoing carotid endarterectomy. As you all know, patients undergoing carotid surgery can have neurological complications because of either intraoperative ischemia related to the cross clamping, or because of embolism, or because of a postoperative hyperperfusion or thrombosis. And so, as we select a neuromonitor for these patients, our goal is to detect these complications early and intervene so we have the fewer complications. And while there are a number of options to monitor these patients, I will say that, and there is a certain amount of bias here, but TCD is actually the only technique that is able to pick up all of these complications. There is no other technique that picks up all these complications. So what happens during these cases as we clamp the carotid, we see a decrease in flow velocity in the ipsilateral middle cerebral artery. And in some patients, it looks like this subtle decrease, but in other patients, there is a very significant reduction, which clearly indicates a need for shunting during this procedure. And the use of TCD to decide the need for shunting has been very well established by a number of studies. Here's just a case example showing a mean flow velocity of 50 centimeters per second prior to clamping, which goes down to 22 or so after cross clamping. It's less than 50% of the pre-clamp value. A shunt is placed, the blood pressure is increased, the patient's flow velocity comes back to normal. And this is the point where the clamp is released and there's a transient hyperemia with maybe some emboli. Again, like I said earlier, there are a number of studies, and one can refer to any of these to demonstrate the superiority of one technique over the other. I like this particular study, which looked at 50 patients undergoing carotid surgery awake. And these patients, despite being awake, had four different types of monitors at the same time: TCD, cerebral oximetry, stump pressure, and SSEPs. And they looked at a change in neurological status and its association with the findings on these monitors. And what they found was that the highest accuracy in terms of monitoring was for a percent change in flow velocity in TCD and a percent change in cerebral oximetry value on NIRS. Again, demonstrating that this is a very effective tool to detect ischemia during carotid surgery. So This is what we use quite a bit here at Harborview, and it's something that many other institutions don't have access to. Another application of TCD that we use it for is to do the bubble testing uh, for um, for detecting right to left cardiac shunts. And interestingly, this is what we use to decide if our patient can be in a sitting position or not. You can see there a shower of emboli. So instead of exposing our patients to TEE, which is more invasive, we can simply do this using transcranial Doppler. And again, that's unique to our institution, unlike other places. When we use something frequently, we become experts at it. And here's an example of a very interesting case that I did with Dr. Shaker some time ago. This is a patient who had a Bow-Hunter syndrome and needed to be positioned with their neck turned during the surgery. We insunated the vertebral arteries, the right vertebral artery, the basilar, and the posterior cerebral artery here, with the patient neck in the neutral position. And after the neck was turned, to make sure that we were not compressing the artery too much, we looked at the velocities again, and we saw that there wasn't much there. So the patient was repositioned, and there was a restoration of flow velocities. You can argue that one could have detected ischemia using evoked potential monitoring, but as you can imagine, it takes a while before evoked potential monitoring is started, and so it would be a little late to identify cerebral ischemia using that modality. Whereas with TCD, we were able to pick it up in the real time and make an adjustment, potentially avoiding a serious complication. And I'm sure you're also aware that we use a TCD as a first-line ancillary test for diagnosing cerebral circulatory arrest here at Harborview. And our patients have and their families have this advantage compared to other more invasive procedures that often require transporting the patients out of the ICU. This is something that can be done on the bedside, and our lab again offers great value here to the institution. Um, Given the institutional expertise in transcranial Doppler, we have been hosting an annual conference and workshop for a number of years now, although we haven't been able to host one for the last few years. And it's again a great multidisciplinary effort, and several members from the departments of anesthesiology and neurosurgery, and also our colleagues from neurology, neurocritical care, and vascular surgery have participated and helped with these workshops, which are really very well attended by a multidisciplinary group of folks from all over the country. But we do recognize that despite all our efforts, the TCD education is limited. So I had the opportunity to collaborate with a great group of people, including colleagues in cardiology and vascular surgery, as well as applied physics and mechanical engineering, to design this mannequin, which basically has a reconstruction of circle of Willis for 40 different patients using their CT angiograms and transcranial Doppler information and computational flow modeling. And basically, it incorporates a mannequin and a mock transducer that can be used by a learner to insunate various cerebral arteries and get real-time feedback and improve their insunation technique. Here's a brief video of what the screen looks like. This thing here shows the performer trying to find the cerebral artery, and as soon as they're able to get into the correct vessel, they start getting the signal, and they're asked to pick and identify the artery, and then they get a real-time feedback of whether or not it in fact was the artery that they were looking for. We have demonstrated the accuracy of the simulator in a couple of studies now, which are in press. But as a result of this work, I had the good fortune of collaborating with Dr. Mike Levitt on a number of other projects, which allowed us to take advantage of the computational fluid dynamics to study cerebral circulation in a number of other different ways, which I'm not going to talk about today. But you can see here a few studies that we were able to co-author together. The other thing I briefly wanted to touch upon is the use of intraoperative jugular oximetry, which is unique to our institution. Although, admittedly, I will say that our use of this technique has reduced over a period of time because of mostly the change in patient demographics, but also because we are very mindful of using this being an invasive procedure. Um, there are places that still use it in the ICU, but I'm not aware of any other institution that uses it intraoperatively. But jugular oximetry has the unique advantages of providing information about cerebral oxygenation and allowing us to manage it by controlling various things, including blood pressure, ventilation, oxygenation, cerebral metabolic rates, oxygen content, etc. I'm not going to present a number of studies here, but just this a case report where Dr. Ellenbogen and I were taking care of a pediatric patient several years ago, and the patient was inadvertently hyperventilated too early in the case, leading to cerebral desaturation. We backed off on the ventilation, and then we increased the patient's blood pressure. We had to use both these interventions before the cerebral oximetry values normalized and the cerebral blood flow velocity also normalized. Um, and this is just a lesson to inform all of us that we should not be using hyperventilation too aggressively and unnecessarily in neurosurgical patients. For the benefits of trainees here, I'll briefly show this video of TCD demonstrating a change in the middle cerebral artery flow velocity with hyperventilation. This is me insonating myself. You can see the mean flow velocity is about 60 centimeters per second. And in about 15 seconds, halfway through this clip, I start hyperventilating. And you can see how quickly the cerebral blood flow velocity starts going down, translating to a reduction in cerebral blood flow. So giving you the message basically that hyperventilation is the most potent modulator of cerebrovascular reactivity, and it can be very effectively used to decrease cerebral blood flow and brain swelling. But it also significantly decreases the cerebral blood flow. So it's not something that we should be using for too long or too aggressively. We can institute it at the time when we actually need to prevent our patients from the risk of cerebral ischemia. Obviously, we can't reflect on this journey without thinking about COVID. I'm sure everybody still has some memories from our not so great experiences and also great experiences during that time. But neuroanesthesia decision making, like anything else, was complex during COVID-19. And again, because of our collaboration, we were able to move forward in an effective manner. I'm sure you all remember our operating rooms looking like this back then. I happened to be the president of our Neuroanesthesia Society that year, so we had the advantage of putting together task forces to come up with recommendations for best practices for providing neuroanesthesia care during COVID-19, especially before vaccine had arrived and when there was a significant concern about availability of PPE. As you will recall, transsphenoidal surgeries were among the first procedures that were identified with the original outbreaks of COVID-19 in Wuhan. And so we had to be involved in this. Uh, but again, along the lines of perioperative neuroscience, we were not limited to just neurosurgical procedures. There was a big increase in psychological problems during COVID-19. A lot of patients were suffering from depression and required electroconvulsive therapy, which requires anesthesia and airway management. And there was concern about spreading COVID and making things worse for patients as well as providers. So we came up with a consensus-based expert opinion on how to manage these patients, and we were able to support the care of these patients, not just locally, but across the country. One of the big controversies during COVID was, again, stroke thrombectomy, where there was a rapidly evolving thought that every patient should be intubated. And this obviously did not make much sense. So the Society for Neuroanesthesia commissioned a task force that I had the honor of leading. And I had to thank Dr. Lewis Kim here, who made very important connections for me. And we came up with this consensus recommendation, and we were able to get endorsements from the 8 professional societies listed here, including Neurology, Neurosurgery, Neurocritical Care Society, both in the US and Europe. And this work was accomplished within a matter of 6 weeks to alert everyone about optimal practices during COVID. Like I said earlier, there are too many stories to share here, and I'm not going to have time to do that. But I just want to remind ourselves that there was a period of time where we dealt with the Aspergillus situation at Seattle Children's, and we effectively moved a lot of children requiring neurosurgery to Harborview. And in that adult environment, we effectively collaborated with our Seattle children's colleagues, both on the anesthesiology side and neurosurgery side, and safely provided care to these patients, which was quite remarkable. There was a period when we dealt with a national shortage of propofol, and we were not able to provide neuromonitoring. And this is the time when we came up with best practices in terms of supporting neuromonitoring without propofol. And again, that was a consensus-based agreement between our departments. Uh, the Department of Neurosurgery obviously went through a large expansion. Our presence at UWMC expanded significantly. The pituitary program grew quite a bit. Awake craniotomies were happening at UWMC, and the functional neurosurgery program has taken up quite a bit. And we have been trying on the anesthesia side to match the pace and provide effective care to these patients in partnership with our colleagues on the neurosurgery side. We haven't been shy of sharing our experience on the global platform, and we have been engaged in some global health efforts, specifically in South America, to advance stroke and TBI care. And just some humbling pictures here to share with you. This is how our colleagues in Paraguay shave their patients' heads. This is the table that they have available for the patients getting spine surgery, and this is the chair for their chair of neurosurgery in the operating room, basically. Nevertheless, they're very enthusiastic folks, and we are glad to work with them and help them improve care. As Dr. Alan Mogan mentioned earlier, we are honored to be the first department, first division in the country to have an accredited fellowship program. And over the years, we have trained several fellows who are practicing in different parts of the country. Some of them are clinicians, others are educators, and some are researchers. And we're really proud of that legacy. Also notable, we are a unique collaborative team where the neurosurgery interns spend a month on the neuroanesthesia side, and the benefits of this can never be overstated. Beyond just learning of physiology and pharmacology and clinical care processes, this rotation has allowed us to build relationships with each other, and our division is truly grateful for this partnership. We get to hear from our residents sometimes even after they leave the department, and that's always such a pleasure. Um, Team building has been great, and it happens both within the operating room environment as well as outside. Here you see Abdullah coming in to check in with David Wright after he left. And at the bottom are our cricket sessions, where you can see Dr. Shaker showing his batting skills. Um, and it has been great fun to get to know each other outside of the clinical spaces. But with all of that, just trying to think of the future briefly, what I see coming is now more of minimally invasive surgeries. And I'm sure you all know more about this than I do, but I imagine we'll be dealing with more endovascular treatments, more functional procedures. We have precision personalized medicine around the corner. I anticipate a lot of advances in neuromonitoring. And even though the procedures will become minimally invasive, our patients' age is increasing and we're dealing with significant medical comorbidities. So anesthesiologists will need to continue to be prepared to deal with these conditions. We are still learning how to harness artificial intelligence to our advantage, but there's no escape from that. I also anticipate changes in training and education, which I believe will be imperative at some point, and not to forget the new practice models and payment models that'll impact all of us. There have been a lot of success stories, but there are challenges. We deal with constant staffing shortages. There is a significant shortage of neuroanesthesiologists across the country. So good anesthesiologists, good neuroanesthesiologists are hard to find. Reimbursement and financial challenges are well known to all of you. Anesthesiology, unfortunately, is one of the specialties with highest burnout rates in the country, and that's something that we are very mindful of, and we're trying to address that. There's also a concern about the balance between service and education for our trainees, and a variable experience in training that's high on our priority to address. We want to protect our academic culture as we evolve these practice models, and there are several other challenges that I may not have time to go into today. So, in terms of strategies for long-term success, as I moved out of this role, and we are looking for our new division chief to take over. And we are all excited to support our new leader. But I think what we'll need to focus on is creating and fostering a positive work environment, creating a positive learning environment where we all can work collaboratively and learn from each other. Strategies to potentially reduce administrative burden, use technology where we can to enable solutions. We'll have to invest in research while we are fiscally responsible, but for me, I feel like it's very important to be driven by vision and mission. Um, and I hope the next line of leaders will be ready to learn from these lessons and take this forward. I'll just end by summarizing that our collaboration between neurosurgery and neuroanesthesiology at UW is unique. We have a lot of collaborative successes in the domains of clinical care, education, as well as research. And our both groups are going through a phase of evolution. We have a lot of younger colleagues that have joined us in recent years. And it's important that we preserve and improve our culture and collaboration as we look into the future. These are the members of Neuroanesthesia Division that have been a part of this great story that I'm super proud of. And really grateful to all of you for all your support over the years, and for your attention this morning. Thank you very much.
So, Deepak, thank you so much for being a pioneer at UW and certainly nationally in developing this fellowship. But you're so many things more than that. It's hard to sum up. Was a wonderful, really a wonderful overview of your vision of where the division should go. And most importantly, as you know, the most important part of our relationship is the collaborative one, the friendship one, the one that we treat each other as equals. It's just fabulous talk. So thank you for doing that. Thank you for your 20 plus years of collaboration and friendship to all of us. You know, it takes all of us to do this. So questions for Dr. Sharma. Rich, no, thumbs up, Dr. Rapport's giving. Anybody else? Uh, I can't see any
Oh,
who hands up. Go ahead. Oh,
uh,
Dr. Kim and then Dr. Shaker.
yeah, Deepak, thank you so much. Great talk. I think everyone should know that Dr. Sharma is not even the best doctor in his own family, with his daughter in medical school right now, and also a superstar in her own right. So, really, uh, on top of all this incredible work, he's an incredible family man and dad and mentor and role model for his very successful family. But you know, I also want to just applaud, more of a comment than a question, Deepak, applaud the fact that you've been willing to evolve the neuroanesthesia team over the many years that we've both been here. And you know, I just want to remind everybody of the days of, you know, incessant jugular bulb, venous oxygen monitoring, and all these sorts of things, which were very useful in certain cases, but became sort of a widespread thing. And you know, we've kind of moved away from that, and you know, look at the care and vasospasm, where we were, you know, hemodiluting and hypervolemia and all these kinds of things, and just, you know, staying on the forefront of neuroanesthesia and critical care management that really has improved the quality of our patients. Vasospasm is now a much more rare condition, and we certainly see it frequently, but only because we have a large volume of subarachnoid hemorrhage patients, and it used to be just a constant, almost daily kind of a, you know, a situation, and now it's much better managed. And then finally, I think really bringing into the fold the full capacity and capability of the UW Medical Center, where Deepak spent quite a bit of time too, as a neuroanesthesia leader. And while there was certainly a cadre, as you mentioned, of experts already there, it was a very limited footprint, and now it's this robust, probably contributing to some of the staffing issues, but robust, incredibly successful service over there with full neuroanesthesia capabilities, and we look forward to the next 10 years working with you. Thank you.
Thanks. Professor Shekar.
So that's a
Dr. Kim.
very, very elegant statement from Dr. Kim. It's hard to follow up on that. So Deepak, I want to say that something a little different. I give lectures around the world, and I always have, as part of my lectures, a slide which illustrates the aspect of neuroanesthesia. And I emphasize to all of our people, meaning neurosurgeons, that is this operations that we do are really a team effort. And what we used to call the ether screen, the people on the other side make a very critical difference. And as you know, we have very good discussions before and after, and we have evolved certain practices which may be very safe for the patient. Lumbar drainage during Moyamoya disease, burst suppression, blood pressure elevation, etc. I've had the privilege of working with neuroanesthesiologists since my days in Pittsburgh, and then GW, and here, of course, you and Dr. David Wright and all the others. I think it's very important for our residents to understand that they need to gain some understanding of what is happening there, because here we take things for granted, but they may go to another place where things are not moving as smoothly. And I appreciate your contributing to our various books and seminars, but I think it's good to have some type of formalized education for our residents so they can understand exactly what you do, because the residents obviously are focused on neurosurgery and they just see the start and the end and so forth. And I once again appreciate all the collaboration and the leadership you and David and all the others have provided. And you are part of our neurosurgical family, as you know. And we thank you for the excellence of care that is achieved here. At least I can speak for Harborview Medical Center. I don't know much about UWMC or the other places, but thanks again.